I'm Dr. Deva Boone of the Southwest Parathyroid Center. Today we're continuing the Parathyroid Education Course. We have so far covered some of the basic topics of how to diagnose parathyroid disease, and now we're going to get into a little more trickier situations. So tonight the topic is normocalcemic hyperparathyroidism. This tends to confuse patients and their doctors a lot. And so I'm excited to cover it and hopefully explain it so that it makes sense. And you leave here tonight understanding exactly what normocalcemic hyperparathyroidism means. We'll even do a few sample cases so you can get some experience with diagnosing it yourself. And figuring out what to do in those cases. Okay, so I am going to get started. Have some slides. Okay, so normocalcemic hyperparathyroidism. We're going to start from the basics and go from there. And it may sound like I'm repeating myself sometimes because with this topic, I kind of have to. There's a lot of misinformation out there about this, and I find myself having to correct kind of the misinformation that's out there. Okay, so first, you have to understand the definitions. Normocalcemic. So normo means normal. The emic part is referring to blood. So normocalcemic means normal blood calcium levels. Okay? Normocalcemic. It's pretty obvious. I'm going to repeat that again and again tonight, right? And then hyperparathyroidism. Well, you should all know what hyperparathyroidism is at this point. It is when you have too much PTH or you have overactive parathyroid glands. So you get high PTH levels, okay? That is the definitions of those terms. So now you know normocalcemic hyperparathyroidism means you have a normal blood calcium level and you have a high blood PTH level. Okay, easy enough, right? This is pretty simple. Okay, the first confusion is, what is normal? Now, I covered this before in one of the earliest talks. Normal is not what the lab calls normal. Our labs tend to give a very broad range for normal. So it's usually somewhere between 8.8 to 10.4. That's not normal. A normal calcium level for an adult is typically somewhere in the 9s. For adults over 40, it's about between 9.4 to 10.0 in milligrams per deciliter. I put the translation on there. It's 2.35 to 2.5 is the normal range in millimoles per liter if you're outside the United States. Okay, but it's not the range that's on your lab slip, so you kind of have to ignore that. The lab may say that an 8.9 is normal. It's not. It's too low. The lab may say that a 10.2 is normal, but if you're 40 years old, that's not normal either. So go by this graph. If you're a teenager or a child, you can have high calcium levels. Over about age 40, really, you should have calcium levels in the 9s. And really, they shouldn't be in the 8s or lowish 9s. They kind of want to be more in the mid to high 9s. This isn't true for every case. There are people who are walking around with calcium levels in the low 9s, and that's totally normal for them. Just like there are rare people walking around with calcium levels in the low 10s, and that's totally normal for them. But in general, most people are going to be in this range of 9.4 to 10. Okay. Still pretty straightforward. Now, this is in huge letters because it's the most important message. If your calcium is outside the normal range, you do not have normocalcemic hyperparathyroidism. Okay? For the definition, your calcium has to be in normal range. It can't be outside that normal range because if it is, then it's no longer normocalcemic hyperparathyroidism. You're going to see why this is so important in a sec. So I get a lot of cases referred to me for normocalcemic hyperparathyroidism, or patients who are told they have normocalcemic hyperparathyroidism. And a lot of them don't actually have it. That's not their diagnosis. And here's why. These are the most common scenarios that I get. Okay, so the calcium levels are all ranging from the high 8s to the low 9s, all of them. probably for years. And now they have elevated PTH levels. So the lab might call a lot of these levels normal, but most people are not in the high 8s to low 9s. Most people want to be in the mid to high 9s. This case is classic secondary hyperparathyroidism, and you treat it by trying to get the calcium up to the mid to high 9s, and once you do that, the PTH level responds and goes back down. So this is probably one of the most common scenarios I get for normocalcemic hyperparathyroidism. It's actually just regular old secondary hyperparathyroidism. All right, the next scenario is this one. It is calcium levels all in the 10s or low 10s usually in an adult over 40. So maybe 10.1, 10.3 with elevated PTH levels. This also is not normocalcemic hyperparathyroidism because again, the calcium level is not normal, right? When you're above 40, you really should have calcium levels in the 9s, not in the 10s. If you're in your 30s and you've got calcium levels of 10.1, 10.2, that could be normocalcemic. But you don't want to go too much above that. But the most common scenario I see is usually these adults, older adults with calcium levels in the low 10s being called normal. And this is actually just straightforward primary hyperparathyroidism. Okay, here's the next scenario. This is calcium levels in the high 9s, so a true normal, and elevated PTH levels, usually very high PTH levels. This is a case of true normocalcemic hyperparathyroidism because the calcium is truly in the normal range. So this is what I call normocalcemic hyperparathyroidism. Number 3 is the only one that I would call normocalcemic hyperparathyroidism. But these other ones get sent to me as normocalcemic hyperparathyroidism, and they're not really. Number 1 is secondary hyperparathyroidism. Number 2 is classic primary. Number 3 is true normocalcemic. So diagnosis, again, I'm repeating myself, but this is so important. You have to have a normal calcium and you have to have a high PTH. That's really it. The normal calcium part is non-negotiable. And the levels have to be always normal. It's not uncommon in primary hyperparathyroidism to see calcium levels go from being mildly elevated, then back to normal range and jump around like that, especially in the early years of the disease. That is not normocalcemic hyperparathyroidism. If you're having calcium levels that are going into the high range, then back to normal, then back to high again, then back to normal, that's not normocalcemic. The levels have to always be in the normal range to be normocalcemic. Otherwise, it's kind of classic. If you have calcium levels high, then normal, then high, then normal, that's classic primary hyperparathyroidism. Right? You treat it just like any other case of primary hyperparathyroidism. Okay. Normocalcemic hyperparathyroidism, because of the things I just mentioned, it cannot be diagnosed with one set of labs. Because somebody will come to me and they have a calcium of 9.9, which is perfect, right? Normal. And their PTH level is 140. That by itself, it looks like normocalcemic hyperparathyroidism. But then I go back and look at their labs, and for the last 4 years, they've had calcium levels in the low 10s. They don't have normocalcemic hyperparathyroidism. They have classic primary hyperparathyroidism, where the calcium level has temporarily gone back to normal, and the next time we check it, we'll probably be back in the 10s. So once I see that their calcium level has been in the 10s, then I can say, okay, that's not normocalcemic hyperparathyroidism. So you have to have a few labs. The other thing is that if you're looking for low labs too, if I see calcium levels that have been on the really low range all this time, then I'm sort of saying, okay, well, maybe that's not really normocalcemic. Let's check it again. If the calcium level is pretty much always 9.1 and 8.9, and then we have one that's in the normal range, is that really normocalcemic? Probably not. Okay. Now, the next hard thing here to understand is that true normocalcemic hyperparathyroidism can be primary or secondary. So I covered primary hyperparathyroidism. Remember that that's a problem with the parathyroids. The parathyroid, like a tumor, there's a growth in one or more of the parathyroid glands. It is producing too much hormone, and it's doing that despite rising calcium levels. So the problem is with the parathyroid. The parathyroid is acting inappropriately. With secondary hyperparathyroidism, the parathyroids are making a lot of hormone, but they're doing that because they have to. They're doing that in response to something else, typically a problem with calcium, either a very low calcium or a problem with absorbing calcium. So primary is problem is with the parathyroids. Secondary is problem is somewhere else, but the parathyroids are responding and making a lot of hormone in response. Normocalcemic hyperparathyroidism can be either, and it's really important to distinguish these two when you're doing the workup for the patient. Okay, so we're gonna do some examples. This is sometimes the best way to understand this is to kind of go through these examples and explain exactly what I mean in different scenarios. Okay, so here we have a 58-year-old woman with osteoporosis and fatigue. Kind of a classic patient, right? Parathyroid patients tend to get fatigue, they tend to get osteoporosis, they tend to get a lot of other symptoms, but those symptoms could be due to other things. So we don't yet know exactly where we're standing here. Calcium levels 9.4 to 9.5. That's a pretty normal calcium, right? PTH is 80 to 110. That's a little bit high. On the next slides, I'll give you the normal ranges so you can see that too. And vitamin D is 25, a little bit low. That's in nanograms per mil. Oh, here we go. The normal labs. So 9.4 to 10.0 is normal for calcium, 20 to 70 for PTH. So our PTH is clearly high, and our vitamin D level is a little bit low. So what's going on? Is this normocalcemic primary hyperparathyroidism or secondary? Well, how do we figure this out? I'm going to go through what I go through in every case. All right. So when I ask you some weird questions, if you get a consult with me and you're thinking, why is she asking about my bowel movements? Who cares? Well, it's actually pretty important. So let's go through the things that I am looking at. Okay. Information I want. Number one, bowel habits. I really want to know about your bowel habits. Do you have chronic diarrhea? It can be something that people don't usually talk about. They don't want to just disclose it right away that they have chronic diarrhea. But if you've got chronic diarrhea, loose stools, you're going to have malabsorption of calcium. It's going to be hard for you to absorb that calcium that you're getting from your diet or from your supplements. And so if you've got loose stools, it's something I want to know. I'm looking out for a lot of these. I'm looking for causes of secondary hyperparathyroidism, reasons that your parathyroid glands might have to work harder. So, why your calcium might be normal, but your parathyroid glands are working harder. What could that be? Well, diarrhea could do it because it makes it hard to absorb the calcium. Your parathyroid glands respond to the calcium, to that drop in blood calcium. They make more hormone and it brings the calcium up, usually at the expense of your bones, but it brings the calcium up. But the issue is that you're losing so much calcium into your stools and you're losing that calcium. Your parathyroid glands know that they're making more hormone, and that's why you get that picture of the normocalcemic. So that's the first thing I'm asking about. Okay. Number two is diet. So do you have any big dietary restrictions? Most people are getting a relatively adequate amount of calcium in their diet. So they don't have to count the milligrams of calcium they get in each meal. But if you do have dietary restrictions, it can make it more difficult to get enough calcium. For example, if you're vegan, the American diet, a lot of the calcium does come from dairy. So if you're vegan, you might not be getting as much as your dairy eating peers. If you are eating a lot of, I always ask if you eat a lot of spinach, and I do that because spinach is high in oxalates, which binds to calcium and causes you to not absorb the calcium. So if you're eating spinach because it's got a lot of calcium in it, that's true, but you're not absorbing that calcium because the oxalates are always so high. And then is there any other restriction in your diet that would make it so that you're probably not getting a lot of calcium or not absorbing it? Supplementation. Do you take calcium? Do you take vitamin D? This is going to be important, especially if I do have a suspicion for secondary hyperparathyroidism. I really want to know what you're getting in. Are you kind of adequately replacing any dietary insufficiency that you have? Okay, surgical history, another really important one. So there are operations that make it very difficult for your body to absorb calcium. One of the most common ones is gastric bypass. So I want to see, have you had a gastric bypass? Have you had anything where your duodenum is bypassed? Because that is the area of active calcium absorption. And during a gastric bypass, that area literally gets bypassed. That's why it's called that. But it gets bypassed. And so your intestines don't have the opportunity to absorb calcium like they normally would. And pretty much everybody after a gastric bypass will need to take calcium or they will develop secondary. I think I talked about this during the secondary talk. Any other operation on the intestines. So a lot of operations on the intestines, like if you've had an appendectomy, you had your appendix out, that's not going to affect it. But really extensive bowel resections, like if you had your whole colon out and you have an endoleostomy, or if you've had a lot of your small intestine removed, those kind of things are going to affect the absorption. Okay, urine calcium. I will get urine calcium, a 24-hour urine calcium in a lot of people with normocalcemic, because it kind of helps to tell me where your body is in terms of taking care of its calcium. So if you've got kind of low-ish calcium levels in your blood, I kind of expect your urine calcium to also be on the lower end because you should be trying to hold on to that calcium. If you're pouring calcium into your urine, that's a separate problem. That's renal calcium leak, which is a cause of secondary hyperparathyroidism. So I am going to check 24-hour urine calcium in cases of normocalcemic. And then finally, I really want to see old labs. Sometimes you can only make the diagnosis when you see the old labs, you see where the calcium level has been. You may not have those. It may be impossible to find them. I get it. But if we can, I really like to see every calcium level that you've had over at least a few years. Okay, so let's go back to the cases. I just put the numbers on so that if you have questions about it, you can refer to the number case rather than having to put a bunch of details in it. You can say, Dr. Boone, I think you made a mistake in case 2 or whatever. So here's case 1. This is a 58-year-old woman. Again, osteoporosis and fatigue, has a calcium that's normal, on the lower end of normal, but normal. PTH level that's high, vitamin D is a little bit low. Okay, so bowel habits. We're going to go through those things that I ask about. Bowel habits are normal, the diet's normal, not taking any calcium, getting some vitamin D in her multivitamin like a lot of people, no relevant operations. Urine calcium, though, is high. When I look at her lab history, her calcium levels tend to be in the low 9s over the last few years. Okay, so calcium level in the low 9s, but a urine calcium level that's high, that is not what you would expect. If you have calcium level in the low 9s and a high urine calcium, this looks like renal calcium leak, that condition where you're just pouring calcium into the urine. Now, you don't have to have kidney failure. I mentioned this before. You don't have to have kidney disease. Your kidneys actually look fine otherwise. They're doing their job. It's just that there's too much calcium going into the urine. This is renal calcium leak. This is secondary hyperparathyroidism. Okay, so it's normocalcemic, but it's secondary, not primary. All right, and the treatment here is treating that urine calcium. So usually medications to reduce the urine calcium. Okay, number 2, same woman. Now her calcium levels are 9.3 to 9.5. Again, a little on the lower end of normal. PTH is again elevated. Vitamin D is the same. This patient has irritable bowel syndrome and has daily diarrhea. So multiple watery bowel movements every day. Vary a little bit, but that's kind of how she lives now. She's also vegan. Not taking any calcium, but taking some vitamin D, hasn't had any relevant operations. Urine calcium is low. Okay, that's what I expect, actually. So if she's vegan, she's maybe not getting enough calcium. She may be, but there's a chance that she's not getting enough calcium in her diet. Even if she is, though, she's having daily diarrhea. So that calcium is not having a lot of time to absorb. And her urine calcium is low because the kidneys are holding on to calcium. That's what we want them to do. That's what we expect them to do if you're not getting enough calcium and you're trying to keep your calcium level up. Okay, And lab history, calcium's been in the low 9s, and now it's kind of still in the low 9s, low to mid. This, again, is secondary hyperparathyroidism. Clear reason to have an elevated PTH, okay? A clear reason that her parathyroid glands have to work hard. Okay, same person, number 3. Now, her calcium level is actually on the high end, 9.8 to 9.9. PTH, though, is 120 to 200, very high. And vitamin D is same, kind of on the low end. Okay, what about this person? Well, not a lot to find here. Bowel habits, everything's normal. Diet's normal, no relevant operations. Urine calcium's normal. Looking back at her labs, they've been in the high 9s for years. Okay, so what is this? This is a true case of normocalcemic primary hyperparathyroidism. A lot of people assume that all cases of normocalcemic are primary because there's confusion around the term, but most of them aren't. This one does look like normocalcemic primary hyperparathyroidism, a true case. Calcium level, high normal. No reason to have secondary, no reason to have parathyroid glands working overtime. And PTH is still very high. Okay, case number 4. It's our same woman. Now her calcium levels are, back to mid 9s. PTH is high, vitamin D is 15. Let's see, she's not on any supplements. Everything's kind of not impressive. No relevant operations. Urine calcium is normal. Labs low to mid 9s. This also looks like secondary hyperparathyroidism. Why? Because the vitamin D is low, and that can raise the PTH level itself. So those kind of mild elevations of PTH, like just above normal, still below 100, but low vitamin D. This looks like secondary hyperparathyroidism due to vitamin D deficiency, and this is treated with vitamin D supplementation, and you may need a little bit of calcium supplementation as well. Okay. Same woman. Now her calcium levels are on the high end again. PTH is 150 to 180, so it's really high. Vitamin D is 50 now, so, the higher end of normal. Okay. She's got chronic diarrhea. She's taking a lot of calcium, so 1,500 milligrams and a lot of vitamin D. Had a gastric bypass as well. Urine calcium is normal. When you look back at her history, you see years of calcium in the high 8s and low 9s. But over the last couple of years, it has gone up because she started taking more supplementation. Now she's on a lot of supplementation and has gotten her calcium level into that true normal range, but her PTH level is still not responding. What is this? Because I'm giving you a case here where that looks like she should have secondary, right? She has chronic diarrhea, had a gastric bypass. I mean, she's not able to absorb calcium that well. And it looks like she did have secondary, actually, because her calcium was low for a long time. But now everything's normal. The parathyroid glands, though, they haven't responded appropriately. They have had to make a lot of hormone. Now the calcium normal, but they just aren't turning off. This is tertiary hyperparathyroidism, which I haven't even addressed yet, but this is tertiary. This is due to long-standing secondary. There's a reason I haven't mentioned it. This is kind of an unusual situation, but long-standing secondary that then develops into a tertiary picture. So this usually we're talking about dialysis patients. Dialysis patients develop secondary hyperparathyroidism that can get quite severe. Once they get a transplant, things can normalize. The calcium level can go back up to normal, but the parathyroid glands in somebody who's on dialysis for years are usually so big and bulky that they can't turn off. They continue to make hormone. The classic scenario, and the one that most doctors think of, is dialysis patients who get a transplant. But tertiary hyperparathyroidism does happen sometimes in other patients. It has to be in cases where you have long-term secondary hyperparathyroidism. You have these calcium levels that are low for a long time. That's stimulating the parathyroid glands. When they get stimulated for long enough, they get bigger. So they get bigger, bulkier. And then if you fix the problem, so with this patient, it may be that she had a gastric bypass and has had diarrhea and was not taking calcium for years. Now we fix that issue. She's on calcium. She's on the vitamin D. She's able to get the calcium up. Parathyroid glands, they're already overgrown. They're already big. They can't turn off, even though they should at this point. This is tertiary. Okay. Hope everybody got that. A little bit of a confusing topic, but you have to have long-term secondary to get tertiary. And usually with dialysis patients, we'll see high calcium levels, high PTH. It will look exactly like primary hyperparathyroidism, but it's not, it's tertiary. And you'll find that during the operation because you'll find hyperplasia. Okay. Number 6, same woman. Calcium is 9.5 to 9.7, truly normal. PTH, a little bit elevated. The vitamin D is lower end of normal, but it's normal. Okay, let's see. Not really impressive, right? No, normal bowel movements, normal diet, nothing really to show. What is this? So I don't have a great explanation for why this person would have secondary, right? No glaring reason for that. But the calcium level, it's normal. PTH level is just a little bit elevated. Vitamin D is 30. This is unclear. Especially the lab history, calcium in low to mid 9s, it's not clear. I don't know. I can't say yet whether this is primary or secondary. I would, want to get more information. If I've already asked all these questions and there's, no smoking gun, there's no clear reason. What I do in these cases is usually see if maybe it's actually secondary, because the odds are this is secondary. More commonly, it is secondary than anything else, because even though I said they don't have diarrhea, they have normal bowel movements, people can have a problem with absorbing calcium even without obvious causes. So in this case, what I would do is give them some calcium supplements and vitamin D and see what happens. And in most cases like this, where the labs are kind of truly borderline for either, most of them will respond to calcium and vitamin D supplementation, and the PTH will drop, usually fairly quickly. So if I see that, it kind of confirms, okay, this was a secondary hyperparathyroidism process. If it doesn't respond, so if I get the calcium level into the 9.9 range, or if it goes into the 10s and the PTH is still not responding, then that looks more like primary, and that's when I would treat it as primary. Okay. Treatment. So primary, we talked about this, it's surgery. Tertiary looks a lot like primary, and the treatment also is surgery. Parathyroid glands can't correct after tertiary, so you have to help them by kind of taking some parathyroids out. For secondary, you want to treat the underlying cause. In most cases, you don't go to surgery. Sometimes you do, but for most cases of secondary, you can correct it by correcting the underlying issue, and then also giving supplements, calcium and vitamin D. And then if secondary goes on long enough, it does become tertiary, and at that point you need surgery. Okay, so takeaways. Normocalcemic equals normal calcium. That is the number one important thing to remember. The lab range is not the true normal range, and it can be primary or secondary. I think most patients come to me when they have normocalcemic and they assume it's primary and they assume that they need surgery. A lot of times, as you've seen, a lot of times it's actually secondary, and the treatment's very different. So the first thing I'm going to do if I see normal calcium levels is try to figure out whether it's primary or secondary. Okay, so great timing, perfect timing. So what I want to do now is go through any questions people have. Hopefully have some questions about normocalcemic and and see what you like there. But I will go through them and in order right now. Okay, Nancy says that she participated in the secondary hyperparathyroidism, but didn't get to post questions. Okay, so diagnosed with secondary. She's been diagnosed with secondary by a nephrologist. The calcium is 9.2. So calcium of 9.2 is a little bit on the low end. So I'm thinking, okay, secondary sort of makes sense. PTH was 55, which is not that high. It's sort of still in the normal range. And then in May, the calcium was 9.4, PTH 77. That's when you started more vitamin D, even though the vitamin D was normal. Okay, sorry. Hold on. Let's see. Okay, so 2024 is when you were first diagnosed. Calcium was a little bit on the low end. PTH was 55, kind of normal. Vitamin D was 55, which is a good level. 2025, the calcium was 9.4 and PTH 77. Finally, the latest results, the calcium is 9.5 and the vitamin D is 87 high. PTH is 41. Urine calcium never done. Okay. So this, especially now, it does look like normocalcemic, but it's secondary because the calcium's been on the low end and you haven't been taking any calcium as far as I can tell. With secondary hyperparathyroidism, yes, you're right, getting a urine calcium would be helpful to see if you're losing calcium in the urine. The BUN doesn't really matter. Again, you can have normal looking function of the kidneys, but have renal calcium leak. So it's worth checking. You also take the 40 milligrams of famotidine. Is it suppressing the PTH? No. And then is 87 getting too high? Yeah, so I'm not sure why they keep pushing up the vitamin D and giving you calcitriol. I don't know why you would need calcitriol if your kidneys are functioning. Calcitriol is activated vitamin D. So if you do have a very severe calcium deficiency, or if you're in renal failure, like close to dialysis or on dialysis, then calcitriol is very helpful because it is activated vitamin D. It's made in the kidneys, and if you have kidney failure, you can't make it yourself, so that's why we give it. Nephrologists love to give it to everybody for some reason, but you don't really need it because your kidneys are working well enough that they should be able to activate vitamin D. It just looks like you need to be on some calcium. And then the vitamin K is not going to make a huge difference. You can take it, but really it looks like you probably need some calcium. So I'm a little bit unclear why you were never started on calcium. That would probably do more to help the PTH. It's to actually take some calcium. Okay. Okay. Robin had surgery on August 20th this year. One adenoma was removed. Calcium is now 8.6. Okay, Robin, that's a little bit low. It was 12.4 before surgery. So it was very high before surgery. You were cured. Now your heart skips beats every day. Do you have secondary hypoparathyroidism? Well, so back up a second. Your PTH now is 106. So you actually have classic secondary hyperparathyroidism now. So Robin had surgery, had really impressive numbers before, had a 12.4, PTH of 300, clear primary hyperparathyroidism, had surgery, they took out the tumor, now your calcium's 8.6, that's too low, and your PTH is 106. That's actually good because that tells me that your remaining parathyroid glands are doing their job. They're awake and they're trying hard to get that calcium level up. I don't know how much calcium you're taking, but you need to be taking calcium and vitamin D to try to correct that, to try to get that calcium in the mid-9s so that your parathyroid glands don't have to work so hard. I'm assuming you have 3 remaining ones. They're in overdrive right now. And unfortunately, that's going to take calcium out of your bones. The harder they have to work, the more bone loss you're going to have. So you want to get that calcium level up from 8.6. Now, if you told me I'm already taking 2,000 milligrams of calcium a day, that's when I would go through all those other questions. So ask about your bowel habits, ask about, kidney stones. Are you losing calcium in your urine? Is there some other thing going on that's making it hard for you to get that calcium or to lose that calcium? So that's what I'd want to do in your case. This is secondary hyperparathyroidism. Yes. It's not that uncommon after parathyroid surgery, actually, for primary hyperparathyroidism. People aren't expecting it, but they get it. And it's usually if you don't take calcium supplements after surgery. Because remember, your bones have lost calcium. You have to replace that. After surgery, it really helps to take calcium and vitamin D supplements. Okay. Shauna asks, should any medications or supplements be discontinued prior to blood work for testing for any type of hyperparathyroidism? Okay, interesting question. The big one actually is biotin, because certain labs, not all of them, certain labs do the PTH testing in a certain way that biotin will interact with it. So if you're on high doses of biotin, you can get a weird result for PTH. Then you just want to stop the biotin. I tell people to 5 days. I probably only need a couple days, but who knows? And it's usually just with high doses, but I tell people to stop any biotin just in case. Other supplements, so other medications you usually don't need to stop. Supplements like calcium or vitamin D, you don't need to stop the vitamin D. For calcium, you probably don't want to get the calcium drawn like an hour or two after you take a big bolus of calcium supplement, because your blood calcium level will temporarily rise for a few hours after a supplement. For most people, it's clinically irrelevant, but if you're really having trouble or figuring out what's going on, I would just, get the labs done in the morning before you take any of your calcium supplements. Okay. So Robin, I'm sorry. Sometimes I can't, go back and forth. So Robin was the one post-op. So it says, I'm eating 4 to 5 1,000 milligram Tums plus a large glass of milk to keep my heart from skipping beats. Yeah, so your heart is skipping beats because your calcium is low. You need to, he thinks you don't have secondary, he could have secondary. Yeah, you do have secondary. And here's the interesting thing about Tums. Okay, I covered this in some video at some point. It's probably been a while. So Tums is weird. Tums is the weirdest calcium supplement. And the reason is that it's an antacid. It's not sold as a calcium supplement. So 1,000 milligrams of Tums actually contains 400 milligrams of calcium. Okay, because only 40% of the calcium carbonate molecule is calcium. So because it's labeled as an antacid, the active ingredient is calcium carbonate. If you're taking a supplement, calcium supplement, the active ingredient is calcium. And then it may say in parentheses as calcium carbonate or as calcium citrate, but you'll notice the active ingredient is calcium. For Tums, the active ingredient is calcium carbonate. So only 40% of that is elemental calcium. So you're getting 400 each time, and you're getting 4 to 5. So you're actually just getting 1,600 to 2,000 milligrams of calcium, which is a lot. That's a lot of calcium. I would at this point check your urine calcium, see if you're losing that calcium in your urine. And it's a good sign that the heart beats, the palpitations get better when you take the calcium, but your calcium level is still low. So it really does indicate that you need to kind of address this. What I would do is, if you're only taking the Tums, you do also need to be taking vitamin D. You need to have the 24-hour urine checked. And then this case may actually be good for calcitriol, because that would help you absorb the calcium that you're getting in your diet and with supplements. Okay, so Robin, I hope you have a plan. You want to check the 24-hour urine calcium. You want to keep taking the calcium, but understanding the dosage. And then also, if you're not getting vitamin D, then you also need to get the vitamin D, because that is necessary for absorption of calcium. And you can start with just over the counter. I usually start with like 2,000 to 4,000 units. Okay. Ashley says, what would be classified with high calcium? 10.8 on the last blood work. Normal PTH and vitamin D in normal range. Okay, so a 10.8, unless, Ashley, if you're 18 years old, that could be totally normal. A 10.8 is not normal for somebody over the age of 30. Really in your 20s, it should start to be dropping down. But a 10.8 is high for most adults. So if you're a teenager, and I don't imagine many teenagers log on for these talks, but if you are, then that could be normal, but that is high. So a high calcium, a normal PTH, that's how we diagnose primary hyperparathyroidism. So that looks like primary if you're an adult over 40 or over 30, really. Yeah. Okay. Kira says, Almonds are high in oxalates. That is true. Yes. Not as high as some other things, but yeah, if you are having trouble getting enough calcium, look at oxalates. The biggest one is spinach. I've just eliminated spinach from my diet because it's just not worth it. Even cooked spinach has so much oxalates. Now, there are some strains. I was reading about a few strains of spinach that, some small farmers grow in certain parts of the world, and they're actually not high in oxalates, but I don't know where to buy these. And honestly, if you're just going to the fries like I am, you got to assume that spinach has a lot of oxalates because most strains of spinach do. So I just avoid spinach. Almonds is another one. I just like almonds too much to give them up, but they do have higher levels of oxalates. Okay. But it is a good sign that the almond milk is helping with it. Even so that's good. I don't know if I'll have to look up almond milk and oxalates. I can't remember. Okay. Karen says, I'm a 48-year-old woman. I had surgery 3.5 weeks ago and had labs done today. The calcium is 9.5 and the vitamin D is 32. He didn't check a PTH. Was that a mistake? No, well, it depends. It's reassuring that your calcium and vitamin D are in a normal range. That is very reassuring. I do like to check a PTH. Sometimes at 3.5 weeks, it can still be kind of fluctuating and not give, still give a weird result. I usually check labs at about 6 to 8 weeks because by that point you do have kind of a stable level of calcium and PTH, and so you tend to get more accurate assessment. But should you get your PTH checked next time? Yeah, I would say so. I mean, especially if the calcium level goes high again, or if it starts to go low, then the PTH will be more important. But it's definitely very reassuring that calcium and vitamin D are in normal range. Okay. Oh yeah, so Ashley's 33, 10.8 is high. Okay, Linda says, years of looking for answers, a 69-year-old, calcium in the high 9s to 10.2 with intermittent elevated PTH levels. Urinary calcium non-detectable with 24-hour urine. Okay, no genetic testing. Okay. Vitamin D is low without supplementing. Okay. Sesame scan negative, bone scan negative. No bypass, no. Okay. Thank you for giving me the relevant history. Thank you. Okay. So the urinary calcium, weird to be non-detectable. Even with low urine calcium levels, we usually see some level there. So I would probably repeat that first just to make sure there was no error in the processing. When you get that jug, it's got a preservative in it. Did something go wrong with the specimen that it's not detectable? That's my first thought. I would repeat that urine calcium. But if your urine calcium is still very, very low, then it would be reasonable to get genetic testing for the genes that cause FHH or familial hypocalciuric hypercalcemia. So if people don't know what that is, it's this rare genetic condition where you have lifelong high calcium levels and lifelong low urine calcium. So high blood calcium, low urine calcium. So if I do see somebody with kind of persistently high calcium levels and then also combined with a very low urine calcium, I do get genetic testing, and it can be ordered online by your doctor. They mail you a kit, you do a mouth swab, you mail it back. Takes a couple weeks. It's gotten much easier and much less expensive to get genetic testing. And so I do, order it, not infrequently in somebody with your picture. Now, if you told me that your urine calcium was actually high when you did, another test, then that would kind of look more like primary hyperparathyroidism, especially since at your age, calcium levels above 10.0 are a little high. So yeah. Thoughts, repeat the 24-hour urine calcium, possibly get genetic testing. Okay, Chill says Vanderbilt has a new method to test Well, there's really no new methods. This is a diagnosis of labs, and the labs are calcium and PTH primarily, and then there's other kind of secondary things you can order. But for the most part, this is a condition that is very well defined by calcium and PTH levels. Okay. Kathy says, have you ever seen low magnesium levels being a cause of hyperparathyroidism? Okay, that's tricky. So magnesium is a weird one in that levels that are too low or too high can cause problems with calcium metabolism. And so with the effect that it has on the calcium, remember the most important factor for parathyroids and stimulating parathyroids is really with calcium levels. So if you have low calcium levels due to low magnesium, for example, because that can happen, really low magnesium levels will cause low calcium. You may see hyperparathyroidism from that, but it wouldn't cause like primary hyperparathyroidism. Okay. Linda Spear asks, is parathyroid dysplasia with normal calcium, vitamin D supplemented to normal levels, and high PTH after 2 parathyroid glands moved, a form of secondary? So I don't know what you mean by dysplasia. I'm assuming that's the pathology report showing dysplasia. Kind of a weird finding to say that, and maybe they meant hyperplasia, but really, honestly, on pathology reports, parathyroid glands vary a lot in how they look under the microscope. So meaning normal parathyroid glands vary a lot from being, hypocellular, not having a lot of cells there and a lot of fat, to having lots of cells and not as much fat in between. Because that's really what we're looking at, right? When you're looking at parathyroid glands under the microscope, you're looking at these tiny, parathyroid cells, and then there's a lot of fat kind of interspersed. And when we say something is hypercellular, all that means is that there's more cells to fat, like it's a higher cell to fat ratio. That's all they're doing. But that cell to fat ratio varies a lot over the course of the gland. And so, for example, if you have a biopsy of a parathyroid, it could look like normal cells, it could look like a little hypercellular. And so about half the time when I take a biopsy of a normal gland, it'll show up as hypercellular on pathology report, and patients always get freaked out. It means nothing. It really means nothing. Now, dysplasia is a weird thing, so I'd want to actually review your case in much more detail, but I'm assuming they probably mean hyperplasia. Now, your calcium notably is normal, and 2 parathyroid glands were removed. I mean, honestly, if I had to guess, I would guess this is secondary rather than primary, but it still could be. Primary hyperparathyroidism, I didn't get into this, but normocalcemic primary does have a higher rate of hyperplasia or multiple glands involved, possibly because some of those cases are actually tertiary. But don't quote me on that because I have no evidence, but I kind of have a feeling that that's maybe why the rate of hyperplasia is higher. But it is higher in normocalcemic, so it's possible. But Linda, I'd want to see what your calcium levels are. Are they truly normal, or are they kind of on the lower end of normal, or are they high normal? It really matters. Okay. Yeah, Robin. Oh, take calcium. Okay. Okay. Rachel Kinney says, Rachel says, I'm 7 months post-op. My post-op calcium lab at fasting is 8.8 to 9.0, PTH in the 40s. I take plenty of calcium, over 1,600 to 2,000 milligrams through diet and supplements. Vitamin D is 42. You've been taking 4,000 units daily since June. High magnesium foods. When not fasting, I've had calcium levels 9.5 and 9.7. I have some symptoms improved, but I still have constant fatigue, muscle weakness, and pain. PTH was missed for over 15 years. So yeah, so your calcium levels look good. I'm not sure why the fasting ones are so much different. It usually doesn't vary that much, but it's a good sign that your PTH level is in the 40s because that shows that your parathyroid glands are kind of relaxed, and they're not having to do a lot. And if you have calcium levels 9.5 to 9.7, that looks good. That's a true normal range, and your vitamin D is normal. So all of these look good. If you do get some of this stuff, I mean, your calcium level is dipping and you're needing a lot of calcium. That's a lot of calcium to take throughout the day. I'm assuming that's not all in supplements. A lot of that's diet. But if you are taking like over 1,000 milligrams in supplements, it would probably be worth checking the urine calcium to see if you're losing that, especially since you're still getting some of the muscle stuff. Yeah. In your 7 months post-op. A lot of people do feel benefits by then, but also a lot of people still need time for all of this to kind of normalize. Okay. Oh, Amanda asks, I recently heard someone talking about vitamin D not working without K2. Is this true? Oh gosh, this is one of those things. So K2, yes, K2, vitamin K2 is essential for vitamin D and calcium metabolism. That is absolutely true. However, saying that it doesn't work without K2 is not true, because most people have this in them already. You're not living without K2. It's not like we just discovered this molecule and you need to start taking it. It's been in your body this whole time. You didn't know about it, but it was there. And maybe people are deficient. We don't have a great, I mean, we have some information about this, but it's getting a little bit overblown right now in people saying, the calcium won't go to the right place without K2. Is that true? Well, I mean, K2 is essential. It is essential for getting calcium to the right place. But does that mean you have to take K2? No. There are a lot of essential things happening in your body that are happening without you taking any supplements, simply because they've been there the whole time and you don't need that supplement. So should you take extra K2? I mean, I tell people, if you've got significant osteoporosis, then yeah, take the K2. It may help. It may help to take the extra vitamin K. If you are just regular post-op, I don't think there's a need to go out there and get vitamin K. And I can't tell you that it's definitely going to help your osteoporosis either. But there's enough evidence that I think it makes sense logically to take it. So if I had osteoporosis, I would take vitamin D with K2. Will the vitamin D work without K2? Absolutely. It works without the vitamin K2 supplement. Does it work without K2? Well, a lot of things in your body wouldn't work without certain vitamins, but that doesn't mean you need to take them because you've already got them. That's I'm going to get off the soapbox. Anyway, I think K2 is fine. I think it's kind of having its stride right now. There's a lot of hype around it. And I think it's not a bad idea to take, especially if you have osteoporosis. But you don't have to run out there and get it. Okay. Marta asks, does multiple bone breaks, 5, impact likelihood of secondary? Fluctuating calcium and PTH over years, usually high normal, lower vitamin D, high urine calcium, many symptoms which get worse with supplementation. I'm 69. No, actually, you'll see bone loss with both primary and secondary. Anything that causes the PTH to be high or the parathyroid glands to make too much hormone is going to cause bone loss. So that fact in itself does not influence whether it's primary or secondary. If your calcium is usually high normal, and if PTH is high with that, then I'd be more inclined to say that that's primary. Okay. All right. Oh, okay. So Rachel, you're not taking a massive amount of supplements. That looks good. I think you're actually doing really well in terms of your labs. I would just, I would probably give it a little bit more time. If things completely don't improve, you can look for other causes of your symptoms. But yeah, the longer you have the disease, I think the longer it takes to recover. Or to reverse the effects of it. So if you've been dealing with this for 15 years, your body needs a little more time. Okay. Ludmilla says, I'm 64 years old, kidney stone since 22, severe osteoporosis, high calcium in urine is 303. If you increase your calcium intake, it goes to 378. PTH is 42 and the calcium is 9.9. All right. After thiazide, diuretic, which is used to treat hypercalciuria, so having high urine calcium, you have kind of a classic renal calcium leak picture where you're losing a lot of calcium in the urine, and that causes kidney stones, and it also causes osteoporosis. Now with the diuretic, your PTH is in the 30s and the calcium is 10. Calcium was always 10 when you were 27 and 34. Yeah, that's normal. When you're 27 and in your 30s, 10.0 is completely normal. In 2014, the TSH was on the lower end. It's still a little bit on the lower end. Calcium levels were 10 to 10.3 until 2019. Okay, well, those are high. Those are high. Then calcium levels 9.6 to 9.9. My parathyroid doctor suspects I have hyperplasia due to long-standing renal calcium leak. That's possibly true. Yeah, so that is possible. You did have a TSH that was low. It looks like a little bit of hyperthyroidism. Could your low TSH and the hyperthyroidism drive the high? That actually can cause high calcium in itself. The PTH level there is pretty important. So if your calcium level was 10.2 due to high thyroid function, then you would expect to see a suppressed PTH. Right now, your labs are kind of perfect. A 9.9 and a PTH of 43 is great. So I wouldn't really treat that because it's kind of perfect. If your calcium level is 10.0 and the PTH is in the 30s, that also looks perfect. I think the main issue that you have was the renal calcium leak. You could develop hyperplasia as a result of that, but honestly, if your labs are this perfect right now with the thiazide diuretic, then it seems unlikely that surgery would help you because the PTH is so normal. Yeah, they usually would only operate on normocalcemic if the PTH is consistently very high, and that's usually like above 100. Okay. Cindy asks, do patients with renal calcium leak have normally low or low normal serum calcium levels because they don't reabsorb the urine and the calcium? Yes, that's exactly it. So they're losing calcium into the urine, meaning they're not reabsorbing it. Like when it goes through the kidneys, it's not coming back into the body. It's just pouring into the urine. And they normally will get low-ish serum calcium levels. It often won't be grossly low. Like I'm not talking about a calcium of 7. It will usually be kind of low normal in renal calcium leak. So low normal and then rising PTH level. Okay. How do we go about getting a consult? You can go to my website. So it's southwestparathyroid.com. And there's a button on there on how to become a patient. And now I welcome anybody to go there. And I'm happy to schedule a time to talk. All right. I think that covers it. So hopefully everybody has a better sense of normocalcemic and can kind of diagnose it now, maybe. And I think I answered all of the questions, and man, this is perfect timing. All right, great. So if that's it, then I will go. Good night, everybody. Thank you for joining, and take care. Have a good evening.